Probably the hardest thing that I still have is deciding which patient is a candidate for arthroplasty with a movable segment versus arthrodesis or fusion. That's the hardest judgment issue, and there's no real clear-cut clinical guidelines to help. What I use are two or three major things. They're all focused on trying to decide how much arthritis and degenerative changes are in the joints at that level. If a patient comes to me with many years of neck pain and now they've blown out a disc, for example, and they have pain, numbness, and tingling down the arm, they would probably be a better candidate to have a fusion done, because again, once the fusion sets up, those arthritic joints aren't moving anymore, so there's a better chance of helping their neck pain and their arm pain. Conversely, on that patient, if I put in a full range of motion system in, it's moving, and now those arthritic joints are moving more than they want to, so they can hurt a lot. So I don't want to put the wrong system in the wrong patient. So people with chronic neck pain are probably do better with a fusion. The MRI scans or CAT scans or even plain x-rays will also give me some criteria. If there's slippage on the plain x-rays, they need to have a fusion. However, if the patient hasn't had a long history of neck pain and has caused a disc herniation, smashing their nerve root with pain, numbness, tingling, and weakness, those are great candidates for cervical arthroplasty for all the reasons that we just said. Those are two clear-cut cases of someone with a lot of neck pain, one with not much, but there's the whole spectrum in the middle, and that's the biggest part of my evaluation when you're in my clinic, is to try to make that very important judgment.